want to thank the California Endowment for their support for this project. And I'm very happy to do a little bit of introduction here and tell you about us, about the webinar, and about the topic. So, Brittany, if you could give me the next slide. DiversityRx is a nonprofit organization that's been in existence since 1977. And we do a variety of things: policy development, research, education, and support for people who work with culturally diverse populations. We have a number of aspects to the work that we do. We have a website called diversityrx.org. We run a very popular listserv on cultural competence issues, and we are the co-hosts of a national conference series, which will actually be taking place this year in October in Baltimore. And then the Your Voice Project has not only this webinar series, but we also sponsor Communities of Practice and other kinds of peer learning networks. So what I'm going to do now, next slide, is to tell you a little bit about the technical aspects of the webinar. We are going to have Q&A as part of this towards the end of the webinar. And the way it works, since we have such a large number of attendees, more than 800 right now, is that we have the audience muted at all times, but you can use the question window on your panel to submit a question to the staff at any point. And you can indicate if you want that to go to a particular speaker, or you can just have it be a regular question. And we'll receive all those questions, and undoubtedly we will get more questions than we can possibly answer, but we are keeping a log of all of them, and we will try to get to as many as we can. On the next slide, you'll see a little graphic that shows you how to ask questions. So you can see on your control panel that there's a question pane, and you type it in. And on the next slide, which is called Keeping Track of the GoToWebinar Control Panel, that's what shows you how to keep your control panel on the screen. If you go to View from the drop-down menu, and you make sure that Auto-Hide the control panel is not checked, then that control panel will stay there with the question pane, and you'll be able to use it at any point. So what I'd like to do next is just go to our agenda slide and introduce the webinar itself and our presenters. As you know, the webinar is called Creating and Sustaining a Culturally Responsive Healthcare Organization, Reflections and Recommendations from the Field. And we're very pleased to have three very experienced people with us today who each work at different kinds of healthcare organizations. Grace Vega is the Language Services Coordinator from the University of Missouri Healthcare in Columbia, Missouri. Diana Carr is the Manager of Cultural Linguistic Services at HealthNet in California. And Mary Mixon is the Assistant Administrator in Hospital Administration at the University Hospital and Healthcare System in Jackson, Mississippi. And the idea behind our webinar today, it's a little bit different than the usual talking head sorts of webinar. What we've asked our presenters to do is to give really just a very brief introduction to a kind of strategy that they have used in order to make their healthcare organization more culturally responsive. They have a few slides, and they're going to give you a brief overview. And then we're going to turn the time over to them for what we call a peer-to-peer dialogue. In other words, they each have taken different approaches to developing a culturally responsive healthcare organization. In that sense, they're experts, and we're going to give them a chance as experts to talk to each other and to ask each other questions. And as you listen to those questions, hopefully that will help you think of questions of your own. And so after about 15 or 20 minutes of dialogue between the panelists, we'll turn things over to the audience, and I will read the questions off to the panelists, and they will answer them directly. And any questions that we have left over at the end, we will collect and send to our panelists after the webinar is over. And hopefully we'll be able to get some more answers back from them in a written form, and then we'll post those answers to our website after the webinar is over. And just so you know, all of the PowerPoint presentations and resources that they might mention are posted on our website, and there will be a URL for that for you at the end. And also, a recording of the webinar will be made available probably about a week after the webinar is over. So with that introduction over, I'd like to turn things over to Grace first and ask her to tell us a little bit about her organization. Grace, are you there?
Sorry, I broke the cardinal rule and didn't unmute myself when it was my turn.
That's okay.
This is Grace Vega, and I was finding myself talking to myself there, telling you that I'd be shaking my boots if I had shoes on. That's the nice thing about these kinds of webinars where no one can see you. I can relax. I hope you will too, as I tell you a little bit about the University of Missouri healthcare system, a little bit about my experience as language services coordinator in working, I'd say, a little bit differently than the other two presenters, kind of from the ground up towards a culturally sensitive and responsive organization. University of Missouri Healthcare is quite a diverse system in the sense of we've got a couple of full-service hospital sites, University Hospital and then a women's and children's hospital, and a psychiatric center. So we have a total of 450 beds. We are a teaching hospital, level 1 trauma center and safety net hospital with 48 primary care and specialty clinics, along with a number of pharmacies that support those clinics. 5,300 employees, one of the biggest employers in the community. There are around 880 medical staff as part of those employees. And interestingly, we are, I know some of you people on the coast kind of consider us out in the middle of nowhere. We're in a very beautiful part of the country in the middle of the United States, positioned between two large cities, St. Louis, Missouri, and Kansas City, Missouri, about halfway between the two. And we are in a town of around 100,000 population, a small community, and with a remarkably diverse group of patients. Our employee distribution, I think, has certainly affected the challenge of creating, I think, a responsively, culturally responsive organization. We are, by all measures, about 85% Caucasian. You can see the percentage, 7.2% Black, 1.4% Hispanic, 3.6% Indian, Alaskan Native American, and 1.7% not indicated. And that really does reflect pretty much the population distribution as well. Next slide, please. Well, we are not on the next slide, but there we go. Thank you, Diana. I'll tell you a little bit about my position. I am a language services coordinator. This job was established about 5 years ago, the position and department, and we have steadily grown as far as our patient population that we serve. The job is to help provide interpreting and translation services for limited English proficient and deaf, hard of hearing patients throughout our system. You can see the data here, around 10,000 interpreter encounters per year currently. If we counted those like some organizations do, those would be, if you counted them every 15 minutes, those are generally at least 1 hour long, so we could say 40,000 by some standards. We have, one of the most interesting pieces is that we do have 56 languages in this town of 100,000 people represented in our healthcare system. And I've given some percentages of those languages that are spoken. That is 50% Spanish-speaking patients. And ASL is our second largest group. Russian and Chinese switch places back and forth for third and fourth most used. And this year, the fifth most frequently used is Burmese. Last year it was Arabic, and the year before that it was Bosnian. And that would be due to our being an area of immigration and refugee resettlement. And that would also account for a lot of the other of those 56 languages. We use face-to-face interpreters for 7 of those languages as frequently as possible. Most of those are PRN, so we don't even have an on-site interpreter always available for those 7. We can use, we depend on a phone interpreting service for a number of those languages, and then we have some limited access to video remote interpreting. I will share briefly, or I hope briefly, I tend to talk a lot. Cut me off if you need to, back over there. I will share, essentially reflect on the steps I took once I realized that my job as language services coordinator really required reaching out into the areas of cultural competency, responsiveness, health literacy, if we were going to truly serve all of our patients well. The first step I would suggest to anyone, and one I took, I would say, with mixed abilities, but I would suggest to all, obviously you're going to need to, and I needed to learn my community. I hadn't lived in Columbia for very long when I took this position, and I needed to learn who lived in our community, and I'm still finding out, obviously, over these 5 years. But certainly different websites on state health facts and census and labor statistics helped with that. But most importantly, I needed to go to the local organizations. We have a Centro Latino, and we have an Asian Affairs Center. We have Refugee and Immigration Resettlement, Health Department, Public Schools. I researched and made contact with all of those people to become familiar with exactly who lives in our community and who we're serving. Secondly, I needed to learn about the many facets of language access, as well as I say, the areas that I realized I needed to educate myself on in cultural competency and health literacy. So frankly, I started Googling, and thank goodness for the World Wide Web. I found all sorts of information, and you've all heard mostly, I'm sure, of the class guidelines, the culturally and linguistically appropriate services guidelines from the Office of Minority Health, Department of Health and Human Services, Civil Rights Guidance to Title VI was very helpful. I used as my Bible something called the Straight Talk, Model Hospital Policies and Procedures, and that was language access, Joint Commission, Cross-Cultural Healthcare Program, and Diversity RX. You'll find numerous resources for information on becoming more culturally responsive through appropriate language access, cultural competency efforts, and health literacy. Additionally, I then realized I needed to research my institution and not only figure out the organizational lines, but the relational lines of service. So I did that by, obviously, as I say, figuring out who related to whom, and then I began to relate the information that I discovered online to those different groups. Ours kind of breaks down into a number of folks. I looked at, we have a CEO, of course, and realized I needed to make financial connections with him. Chief medical officers and medical school deans would be people I needed to get information to clinically, since they worked with the providers and the med students. We have a quality officer, we have clinical effectiveness, regulatory and compliance areas, and service excellence. And I'm sure that virtually all of you have people who may be called something a little different than that, but relate to those general areas of quality and clinical effectiveness and service, and obviously finances. And I started to match those different players, if you will, to some of the resources I found online. If you would give me the next slide there, Diana. Oops. You know what? I'm really not ready for that slide. If you can go back. Sorry about that. There we go. So I did, as far as connecting the dots, start sending information to it, as I suggest here. I didn't always do it this way, but figured out it would have been a good way to begin to send those standards and statements to the varied leaders that I mentioned. There are a number of articles out there on the financial case and they're usually directed to the C-suite, so get to the CEO relating to the financial prudence of cultural responsiveness. And then the AMA, AHA, you could relate to the chief medical officer and medical school dean. Quality people answer to and look to agencies like the Agency for Healthcare Research and Quality, the National Committee on Quality Assurance. So anything I could find relating to cultural responsiveness in the various areas from those folks would forward on to the quality people. Clinical effectiveness people tend to answer to the Institute or look to the Institute for healthcare improvement. And the regulatory people, in at least our setting, are very aware of federal and state licensing guidance and joint commission and as an accrediting agency. I talked to our service excellence people and found out that, especially now, we're very related to what we find from the Institute for Family-Centered Care. So those are all places that I would suggest you go find out what statements are being made, what policies are out there relating to culturally responsive care in the areas of language access and cultural competency. And as I mentioned, start sending those, getting that information out to the leaders. And then follow up. I think one of my biggest challenges was not to be afraid to do that, considering I'm not at the administrative level in that sense, but following through with and then inviting to some of the training opportunities that are out there. Second piece of connecting the dots would be to find committees in your organization. And for instance, in our organization, either I am on or one of my staff people in my department is on committees like the Patient Rights and Organizational Ethics Committee, Palliative Care Committee, New Patient and Family-Centered Care Committee, that's just groups that are just being formed. And then, interestingly, we have started a program, an initiated program to call patients from all areas of service to follow up on their care, to check on patients. And that's been an interesting committee to be on because I actually reach areas of registration and other areas that perhaps hadn't really thought about even just how to ask particular questions in a culturally responsive way. So there are lots of potential committees out there you can participate on to help educate around cultural responsiveness. And then lastly, for the teaching institutions, academic settings, I think collaboration is absolutely necessary to connect the dots and make sure that you're getting the usage out of everyone's knowledge throughout the system, and so that you're not isolated. As in my case, since we started the work from the perspective of providing help, interpreter and translation services, the tendency was to think or have people say, well, these are your patients. And in order to make sure everyone realizes these are our patients, we need to be in collaboration with our med schools. Family and community medicine has been an absolutely terrific area to partner with in cultural competency and language access through presentations and trainings and simulations. We stick our interpreters in for some of the simulations with med students, and it's been a real eye-opener, I think, for those folks when they realize there's a whole lot more going on than miscommunication through language issues. School of Health Professions and Nursing, we have also been invited and continue to look for opportunities to present through those arenas. And health policy. We have a health policy organization here which is driving health and health literacy efforts, especially in the area of reducing health disparities. And they're excellent people we're finding to partner with in all around cultural responsiveness. The medical ethics folks, certainly you can get in on. I went to some trainings with them and actually didn't realize that I was supposed to be a researcher presenting some of my research or my papers, and asked to be part of one of their forums, and they let me. And it was really a beneficial opportunity to share what we are doing, what we'd like to do in cultural competency. Resident training, another area. Orientations, committees, service teams. And then lastly, if you give me the last slide, Diana, I have this one titled Soapbox to Solutions. If I can find it. Sorry, gang. I got timed out here. And it is about the fact that, and I actually, again, I'm speaking from my own experience. Since I was 10 years old, I've had a tendency to get on a soapbox and say things like nativist to my sister's girlfriend when I didn't feel like he was responding appropriately, and so my passions at times have overcome my sensitivities to those I'm speaking to. So for that reason, I've got listed as it's not what you say, it's how you say it. I get that from my boss with great frequency, and it's actually a good reminder to all of us who maybe are fortunate enough to be a little farther along in the understanding of cultural sensitivity, cultural responsiveness. I discovered that one of the things that I had issue with was when what I considered to be pointing out a problem in order to solve issues was received often as finger pointing. So I would encourage you to remember to be very clear that when you are telling stories, giving case histories, which I think are important strategies, that you make it clear that those are simply for the purpose of identifying problems and solving them. Additionally, my next point would be that it's what you say and where you say it. And in this, I'm relating to the fact that I discovered that kudos were a really good way to get folks to jump on the train rather than simply pointing out the deficiencies. We like to do that, find different ways to do that, and obviously where you say it can be and is often good if you say, commend people for even the smallest movements forward in front of their bosses. That's pretty darn effective, I've discovered. We're starting to send out emails to folks to commend them, doctors particularly when they've been particularly helpful and responsive to a patient. And again, we CC their bosses. Get that out in front, and that does a couple of things. Obviously, it creates good working relationships, that people are happy that they've been commended for what they've done and in front of their bosses, but it also is a way of educating. You can quickly refer to one's particular ability in improving service, and it reminds people that this is an area that is part and parcel of what we do. And then finally, I would recommend, again, I'm speaking from my experience, it might resonate with you, might not. You may be a little bit better at this than I am, but when I say it's not what you hear, it's what they mean, I'm recommending that you try not to assume anything or cast ideas as to why a person is responding the way they're responding when you present an issue of what you might consider insensitivity to another person's cultural needs. I can give as an example, recently I was asked to do a presentation with some other staff in our palliative care committee, and it was in response to a request from an intensive care unit where one of the staff members, an Indian patient had died. The family was Hindu, and he had quite a complicated medical history and had a lengthy stay. And one of our staff members was concerned about the difficulty that the staff had with what he perceived was difficulty with differing cultural perspectives. And so we presented to discuss some of the issues that arose and how things might have been addressed differently and might be in the future. And a nurse at that presentation complained that what I heard was the family's grief process had meant that she couldn't attend to her duties. And as we discussed that a little more, I realized that from her perspective, to be respectful of the gentleman and his family, she needed to get in there and get the machines off and get him cleaned up and get him ready to remove from the unit or move him from the unit so the family could grieve in private, and that also other families wouldn't be disturbed. I think there were a lot of, I was told that there were children who were somewhat frightened by some of the grief process that observed around them. But from the family's perspective, they were following their cultural and religious map as to the grieving process, and which required that they express their grief very openly and emotionally, and it also required that male members attend to the body. So rather than simply determine that that staff person didn't have a clue, which was my initial reaction, I knew that I needed to remember, as we all do, that our job, if part of our job, or our job is to help create a more responsive culture of its own, we must provide opportunities for our staff to do what cultural anthropologist Dr. Linda Hunt from Michigan State suggests, I think, is key to being culturally sensitive. She suggests that we should help our staff explore and discover their own cultural orientations and perspectives regarding health and illness, and then to learn how to respectively discover that of each of our patients and families, be they from Southwest Missouri or Asia. And then, as Dr. Hunt states, help them to explore compromises that would be acceptable to both the provider staff or their staff and the patient. That's what we're striving for here at University of Missouri Healthcare, and I welcome opportunities to answer any questions or receive some more knowledge from the rest of you as we continue in this presentation. Thanks very much.
Great. Thank you so much, Grace. We really appreciated hearing about some of your insights and experiences at your healthcare organization. I would like to turn things, and just a reminder to everybody who's listening, the resource slide that you see here that Grace has given to us is going to be part of the PowerPoint presentation, which you can find on our website. And so you don't feel that you have to feel the need to copy this all down, because you can go to the website after the webinar and download this. So I'd like to turn things over now to Diana Carr, who has worked for many years in California on cultural and linguistic and diversity issues, and she is at HealthNet, which is a health plan in California, and she's going to tell us a little bit about what she's learned at her organization. Go ahead, Diana.
Thank you, Julia. I think you'll find some overlap between what Grace had to say and my perspective, but I want to share with you today the perspective from a for-profit health plan. So that one of the things I wanted to stress is that we don't have direct patients. Our primary responsibility is connecting a wide range of consumers together with a wide range of service providers. And so one of the things that I discovered early on is that people do really, the decision makers in the organization really do want to do what we consider the right thing, but they are making hard choices all the time. And it's really incumbent on us then to give them the business reasons that make it easy for them to do the right thing. One of the things that I really wanted to stress then is that this is more of a business approach, but a lot of times that's what we need to get things started, is really to align our passions and the need with the business approach as well. So one of the first things I did is wrote down the guiding principles, things that help me keep the program on track. And I haven't done all of these, or HealthNet hasn't done all of these. Some of these were recommendations that have come to us through other collaborations. I think one of the big items is making sure that you align your program with your organization's strategic goals and identifying all of your stakeholders. It isn't just the individual patient, consumer. We also have employer groups as consumers. We have many medical points of contact, not just the physician. There's labs, diagnostic centers, pharmacies. All of these are stakeholders that are impacted by cultural awareness and cultural sensitivities. And then the big stress is begin. Don't be afraid. Begin. Make some step. Don't get bogged down in the planning to the point that you don't begin. So I wanted to go over some of the basics for making a business case. And like Grace mentioned, one of the first things to consider is to really know your organization, really know your operation. And so when you sit down and look at how your organization connects your consumers to your healthcare providers, what are the various departments that might be impacted or need the support of cultural competency? And I found a few surprises in my organization, at least. Sales, for example, isn't an organization or a unit that you would think would be directly impacted by cultural awareness programs, but they fill out many requests for information. It's what the employer group business is based on. And more and more and more, those requests for information are really include a lot of questions about patient-centered quality of care, health plan progress towards Healthy People 2020, questions on health disparities or equal treatment of patients. So a cultural awareness program could be a great support for them. And they can become, in return, very influential allies. So reaching out to these individual departments and finding out how they would be impacted by cultural competency. But that means that you have to really have given a lot of thought to what cultural competency would look like to them. Is it member satisfaction? Is it being competitive? Is it utilization of services? Is it customer loyalty? What would it look like to them? And there isn't a lot of research in this area. There is some, but not too much. There are some studies that indicate, if you give appropriate literacy information, you can reduce ER visits. And literacy, of course, applies to limited English proficient speakers as well as it does to English proficient speakers. But there's not a lot of cause and effect. It says, if you provide cultural awareness information, is your member satisfaction really impacted? There's some anecdotal evidence, but not systemic-wide type of evidence. The next one is begin where you are. Getting to know your culture's own organization. Who is it in your organization that's open to cultural awareness programs, that can help support the value of cultural awareness programs? And they don't need to, your champions don't necessarily need to be somebody that can take your initiative forward or take it throughout the organization, but they have to be that support system that you can use to build on the shoulders of giants, step at a time, building links. So sometimes you can't quite put together a whole organizational-wide program, and it depends on how big your organization is. But you can start out in different units or with small successes and keep using those as the building point. Thinking about what aspects of your organization would best be suited to cultural competency programs. Where do you think the most bang for the buck is? And this gets back to, again, being familiar with your regulatory, with your accrediting agencies, with your community that you're serving. Who is it out there that would get the most bang for your buck? But you also have to know what cultural awareness would look like to them and have it thought it through. What one success will have the most impact on the membership. One of the ones that I wanted to stress is working in collaboratives. You may find that many of your competitors or folks in similar situations are facing the same issues, how to provide language access services in a way that is cost-effective, but also in a way that gets utilized. In California, we have a new state law that requires language access services, and all of the health plans are providing language access services, but they're fairly low utilization. So what kinds of things can you do together to help with that utilization, to help with the promotion, to help identify that kind of shared opportunity? Sometimes knowing what your competitors are doing, depending on your cultural organization, your motivation could be keeping up with your competitors or being the first to do it out of your competitors or doing it better than your competitors. It kind of depends on your cultural organization, but there's always something out there. So don't overlook that avenue. Listen to your consumers. There, again, the research is thin, but there is some out there. The California Health Information Survey, Cal Berkeley, University of Berkeley just released a patient feedback study where they patients in the Medicaid program and in the commercial HMO program specifically stated the areas that they're confused by in terms of accessing health care. So look for ways to talk to your consumers directly and then tell people about it. Tell people in your organization about it. What do these consumers have to say? Share that research, circulate it, make sure it gets a lot of attention. Then I wanted to give some building blocks that everybody can use so that you can start just where you are. One is celebrate culture within the organization, and there are a couple of ways to do that. We've held, for the last 7 years, we've held a cultural heritage exhibit, and it's now in 7 locations throughout our organization, and it's made up of displays that were created by our associates themselves. So because we're all come from such diverse backgrounds, they bring in little snippets of their own culture, and we do a nice presentation and a nice display for them, so it has kind of a museum-type presentation to it. And it helps us learn about culture through ourselves, and it also helps encourage us to be more accepting of each other. But there have been lots of other different types of celebrations. You can host a cultural celebration. You can host a multicultural art exhibit. We've done a cultural recipe exchange where you're not only exchanging the recipe, but a little brief blurb about it. Ours was on comfort food and why it was a particularly successful comfort food. Know the research, circulate it, promote it. Identify the key issue that would be of the most benefit to your organization or similar organizations and build a collaborative around that. Promote cultural awareness activities by supporting accrediting or regulating functions within the organization. Sometimes you can take what has been viewed as the minimum to meet the accrediting standard, but you can expand on that. And expanding on that can take you quite far within the organization because it makes it easier to meet that accrediting goal. Pitch your ideas in your key areas and work on those. What's in it for me? Keeping in mind, again, what does cultural awareness look like for that unit, for that department, for that aspect? My example here was cultural awareness activity could improve the organization's responses to the Pacific Business Group on Health, RFI, by being able to say, we do these activities, we have this kind of research, we address disparities in this way, what kind of data collection do we do? So being specific and being aware of your your organization's own cultural background. And that's it for me. Julia?
Sorry. Now you can hear me, right?
Yes.
Sorry, I had a little trouble unmuting myself. Thank you, Diana. That was an excellent presentation, and we appreciate your perspective from California and from the perspective of a very complicated health plan. I'd like to turn things over now to Mary Mixon, who's going to tell us about her experience at University of Mississippi Healthcare. Mary, why don't you go ahead?
Good afternoon, Julia, Diana, community of practice members and guests. Today I'll be speaking on our utilization of an organizational communication climate assessment tool. Next slide, please. The University of Mississippi Healthcare is located in our state's capital in the city of Jackson. It's the state's only academic health science center with 8,500 employees. Our 4 hospitals collectively total 722 beds, admitting 27,000 patients annually. Our outpatient and our ER take care of more than 500,000 patients a year, and we are the state's only Level 1 trauma center and organ transplant center. Our Neonatal Intensive Care is the highest level, a Level 3. A major goal of the medical center is the elimination of differences in our health status of Mississippians based on race, geography, income, or social status. Next slide, please. In 2006, the University Hospitals and Health System was selected by the AMA Ethical Force Program on Patient-Centered Communication to participate with 12 other healthcare organizations nationally as a field test site for an organizational communication climate assessment toolkit.
Two of our UHHS core values, communication and diversity, supported this effort. The AMA Ethical Force Program and their National Expert Advisory Panel provided us with a 360-degree assessment on our communication performance in 9 content areas. Information on this toolkit is available at the ethicalforce.org website. Next slide, please. The 9 content areas include understanding your organization's commitment, collecting information, engaging communities, developing your workforce, engaging individuals, the socio-cultural context, language, health literacy, and evaluating performance. The toolkit developers reported that most of these communication domains are significant predictors of patient-reported quality of care and trust. The surveys were distributed to both clinical and non-clinical staff, patients, and executives in selected areas.
Mary, could I just ask you to speak up a little bit?
Okay, I'm sorry.
Thank you.
An organizational survey was also done. The survey findings identified some disconnects between the leadership's perceptions and the clinician's experiences. For example, meeting the language needs of the patient. The AMA Ethical Force Program gave specific and detailed reports for each domain, along with recommendations of things we could consider for improvement. For example, we should be giving our patients specific information on who to call if they have a question or want to express a concern. Some of the recommendations are easier than others to implement. Some require careful planning, but overall these were very helpful. Next slide, please. In 2008 and 2009, we also participated in a 2-part Phase 2 as one of the 9 healthcare facilities to validate the hospital's performance assessment toolkit through coordinated, targeted quality improvement interventions. We asked staff in our ED rapid track area to use the teach-back method, and we also asked our inpatient cardiology floor to use the Ask Me 3 method. Between the 2008 survey results and the 2009 results, in the domain of health literacy, we saw an improvement in our scores. Another intervention used was the Worlds Apart video by Fanlight Productions, followed by a directed group discussion. It was not clear which domain was specifically impacted, but we also saw staff in that department begin to provide their own in-services, like on how to work with an interpreter. Overall, we saw an improvement in the scores between the 2 years, except in one of our areas, that is language services. Some of the ongoing process improvements we have been working on include the training of the admission and registration staff on how to ask patients about their race and ethnicity in a consistent manner, improvements to our wayfinding processes, training the staff on how to access and utilize interpreters, increasing our translated documents and making them more readily accessible in the electronic form. And our Office of Patient Affairs has created an informational staff newsletter focusing on our customers and cultural sensitivity. In summary, with this toolkit, we were able to take a valid 360-degree assessment on our communication performance, utilizing the 9 domains. The assessment results can be useful for tracking an organization's performance, benchmarking, and to inform tailored quality improvement interventions. I'd like to thank Dr. Matthew Winey and his staff for their support of us and for sharing this toolkit with us. Okay, went to the next slide. The leadership here at the University of Mississippi Healthcare continue to demonstrate their commitment to eliminating healthcare disparities, and in 2009 invited Dr. Joseph Betancourt, the director of the Disparities Solution Center here, at the Massachusetts General Hospital in Boston, to speak at our annual Wallace-Connerly Health Policy Symposium. He spoke to us on improving quality and achieving equity, developing solutions to health disparities. His presentation was attended by nearly 200 physicians, students, clinicians, and others. And afterward, he met with our senior hospital leadership, some key faculty, representatives from the Vice Chancellor's office, and others. And from this meeting, our CEO requested that I develop and chair a Healthcare Disparities Council for the hospitals and clinics. The mission of the Council is to identify key areas where racial and ethnic disparities may exist here and to develop solutions to eliminate the disparities. The second group to be developed is a Multicultural Advisory Committee composed of community leaders, patients, and family members from our minority communities. The purpose of this committee is to advise the hospital and clinics on the minority patients' experience of care and their perception of the hospital in the various communities. This program is modeled after the Massachusetts General Hospital Disparities work, and I am pleased to report that our Healthcare Disparities Council is up and running with 40 members. We have physicians, nurses, interpreters, patient advocates, representatives from the Vice Chancellor's Office, registration staff, pastoral care, and other departments. Next slide, please. We also have 3 subcommittees. We have an Access and Patient Experience of Care with the overall goal of assessing the experience of care of our patients, identified as racial and ethnic minorities. We have a quality group with the goal of stratifying quality measures by race and ethnicity, as well as designing some improvement initiatives to address any issues found. And third, we have an Education and Awareness group with the overall goal of developing plans to educate us about disparities and to develop a resource directory. Although it does take time to launch such a large effort, we feel that we are coming together well. For example, our quality group has begun to drill down on the patient data collected on admission and has added the patient's education and socioeconomic level to our pre-anesthesia electronic screen on a trial basis. The Quality Subcommittee will be developing a disparities dashboard for us in the future. The Access and Patient Experience of Care group will be working with me on establishing our Multicultural Advisory Committee rollout. They currently collect anecdotal feedback as they visit patients and staff on the inpatient units and are looking for trends to report on. We feel that from this feedback, some cultural sensitivity training may be identified for a specific unit or department. And the Education and Awareness group has plans to increase communication in a 3-phase rollout. First, by intercommittee with a shared website called SharePoint. Secondly, to the internal medical center on our intranet. And thirdly, to the public on our internet site. The goal for the cultural awareness training is to provide a program at least once a quarter. And the leadership team will be educated first. Also, within our Healthcare Disparities Council meetings, we discuss any webinars that occurred during the past month so that the Council itself can continue to grow and become more in tune with the cultural awareness. So in conclusion, we feel that we've made a good start with the support of Dr. Matthew Wynia's work on the AMA Ethical Force Program and Dr. Betancourt's guidance on our Healthcare Disparities Council. We'll continue to grow and seek feedback in forums such as our listserv, communities of practice, and webinars. Thank you.
Thank you very much. That was very good, Mary. Before I turn things over to the discussion period, I just wanted to ask you if you could clarify a couple of terms that people might not be so familiar with. You talked about the teach-back method, Ask Me 3, and wayfinding. Could you tell us a little bit more about, just very briefly, about each one of those?
Okay, very good. Thank you. The teach-back method is actually a method where the patient recounts what he has been told during the informed consent discussion or any teaching moment that you have with the patient. If you're demonstrating how to change a wound dressing, then they would show you back and discuss it back with you so that you're sure that they know what you've taught them. The SB3, I think you asked about that, is
right.
A program provided by the Partnership for Clear Health Communication. And what it is to promote awareness and solutions around the issue of low health literacy and its effects on health outcomes. So it's designed to enhance communication between the providers and the patient. So the patient, for example, on our cardiology floor, they were given a pamphlet upon admission, and it had 3 questions on it. And as their healthcare providers came around, they were to ask these questions and write them down and be able to discuss them before they went home. The first question is, what is my main problem? The second question is, what do I need to do? And the third question is, why is it important for me to do this? So they understand their health issues. The third question you asked, I believe, was about wayfinding. And for us here, it's the signage, the symbols that we put around the building. We have the basic signage package around the medical center, but how do we make that more clear for our population? We decided to use some symbols with our signage and some common symbols, and we went to some websites and found some accepted symbols to use. Does that help?
That helps quite a bit. So thank you very much. So what I'd like to do now, just to give you a sense of where we're going at this point, we have about a little bit more than half an hour. And so what I'd like to do is turn things over to the presenters. And I know that they have some questions for each other and maybe a few issues to discuss. We'll do that for about 15 minutes. And then I will start to ask the presenters some of the questions that you've been emailing in to us. So if we could start with Grace, do you have anything that you'd like to direct to your fellow panelists? Grace, are you unmuted? Since we all seem to be having a problem with that today. Is that you, Grace? Okay, how about if we, Mary, since you are still, I think you're still on.
There we go. Sorry.
Okay, that's quite all right.
It kept coming on and off. Sorry about that.
That's
Mary,
all right, Grace.
Mary, I have a question that I've wanted to ask you. I've heard you mention this before. The field testing of the tool for ethical force. I am curious how you get to participate in something like that. I know you stated that you were selected one of 13 to participate in that. So tell me a little bit more about that, because obviously that would be an amazing thing to be part of, something like that.
It was an amazing thing to be part of, and that field test is over, but those resources are available at that website, and there are around the country, I understand, several people trained to assist you if you want to use the survey tool. But what our Vice Chancellor for Multicultural Affairs evidently applied for this to participate and was accepted. I think that they were looking for a diverse group from around the country, and I wasn't actually involved in the application of that, so I don't know what that application looked like, but it was very exciting. And the first phase was done through the Office of Multicultural Affairs in participation with the hospital, and then it was turned over to me to continue the validation surveys. It was very exciting and very helpful. We received a lot of good information back. And that, like I said, that tool is available, and those domains are available for review through, I guess, the ethicalforce.org.
Okay, thanks.
Grace,
Yes.
Anything else that you might have?
Well, not at the moment. I'm probably going to have another one here in a moment, but
that's quite all right. Diana, how about you?
I actually had another question for Mary as well. You mentioned a staff newsletter, and I was just wondering if you could share a little bit more about the sort of goals for that staff newsletter, who's responsible for its production, and how some of the logistics around that.
Okay. Our Office of Multicultural Affairs, hold on just a second, let me clarify that. Our Office of Patient Affairs, I've lost my place, has a Choctaw liaison, has our interpreter services, has variety of folks in that department, and they chose to put together a newsletter to help begin to educate our employees. Like our Choctaw liaison may write some comments about we have our Native Americans here are Choctaw mainly in this state, and she may write something in the newsletter, educational, about when you're interacting or teaching with the Choctaw population, please consider these things. Even though they're general, we realize you have to deal with the individual patient and their individual cultural specific needs. But it has been received well. It's also tied in with our feedback from our patients. When the Office of Patient Affairs staff make rounds, they get feedback from, they give us feedback on how their stay is, how their experience of stay is, and that information is summarized and will be shared in the newsletter, compliments and concerns. And staff take that information and try and work towards some goals, unit-specific goals based on the results of that newsletter. Did I cover your questions on that?
Yes, so it sounds like the newsletter is sort of used as an ongoing assessment tool.
Yes, it is.
Very interesting. Very interesting. Diana, did you have any other questions?
I had another question for Grace. And I know, Grace, you were mentioning some of the struggles in trying to address a healthcare system. And I'm wondering if you had any sense as to willingness to embrace some of the changes and strategies that you recommended. Are you finding it more challenging on the clinical side of the house or on the staff side of the house, or they both just have their unique challenges?
Well, I would say they do have differing challenges. Interestingly, though, and I would say partly because of the opportunities to educate, it has been harder to get the opportunity to educate clinical staff. Partly because it's often the time crunch. You've got a lot of, in our situation, a teaching hospital, we've got large numbers of residents who have a particular program, an educational program that they're supposed to be addressing, and the lack of time. And so what I've realized is I have to become part of that educational program. I have to get in and get the folks in the areas that make decisions as to content realize that cultural responsiveness needs to be part of that teaching. And we're getting to that place. It's really gotten exciting in the last few months because as part of a new initiative to really work on patient family-centered care, the idea that obviously cultural responsiveness is going to improve patient family-centered care, the understanding that should be and can be part of the training of residents as well as students in the medical school is starting to come together. So that's getting better. I had more opportunities to reach other staff through monthly meetings that they have. Getting scheduled sometimes is tricky, but if you're pushy enough and just keep asking, finally they get tired of you. They'll say, okay, we got you on.
Persistence pays off.
It does. It most certainly does. Diana, I had a question for you, and actually it's for you and Mary, because I said we're starting from the standpoint of we have a language services department, but I noticed your title is, let's see, I had it here. Yours is a title of language and cultural, what is it exactly? Diversity.
Cultural and linguistic services.
Right. And then Mary is an administrator who has been asked to take all of this on. How did you all get to those points? I guess actually I've heard a little more about Mary's, but Diana, how did your department, how was it initiated? I'm curious. And how was the decision made to expand and not be, silo out language services, but understand it as a larger concept?
I think there are two issues. One is that the department itself began by serving the Medicaid population in California. And in California, we have an incredibly diverse communities anyways. And there's a great deal of diversity in the folks that are qualified for Medicaid. So the Department of Healthcare Services in California said, we've really got to deal well with these people to make the healthcare provision as effective as it can be. So that's how the the department got started, is that the Department of Healthcare Services in California had some very specific requirements around the types of services that needed to be provided for this diverse population. And then over time, when I came in, my background's a medical anthropologist, and I had the linguistic background and I had the cultural background. And so we kept growing our programs and services, and using some of the strategies that I talked about earlier, we expanded that out to many of our lines of business. And then in 2008, California enacted and became effective 1/1/2009 language assistance regulations. And part of the language assistance regulations also require a cultural type of report. So just over the years, we've been able to really build on these small successes and expand.
Great, thanks.
Grace, I'm a nurse by trade. I've been a nurse 31 years, psych mental health, and I've been in administration many, many years, and I was asked to start an Office of Patient Affairs. And in doing so, this falls right in line, working with patients and their families, meeting their needs. And then I began to work with the AMA Ethical Force Program. And after that, I went to Diversity RX, and it was wonderful in Minnesota. It was wonderful. I really enjoyed it. Came back all excited, and then Dr. Betancourt came, and it just everything fell in place with the Healthcare Disparities Council. And so it has, and the support from our administration has been wonderful.
That's terrific. Thanks for sharing that. I'm hoping some of my administrators are listening and are going to capture the capture the fire here.
Sure. Anybody else want to pose a question to each other? Okay. I actually have dozens of questions that have been sent to us by all of our listeners. So let me just preface starting out the question period here with one thought that I have. A number of you have asked about some very specific things. What kind of cultural competence training do you recommend? How do you go about collecting race, ethnicity, and language data? What sort of checklists and tools do you use for evaluation? And what I'm going to do, instead of posing those questions to our panelists, is send those questions to them after the webinar, and that way they can just write down what the tool is or what they use and where you can find it, which I think will be much more productive than trying to give that information on the webinar right now. So I'm going to go to some of the sort of the bigger questions. And one of the ones that we have here is, what are some of the best strategies for working with administrators or employers who are resistant to the notion of creating a culturally responsive organization? Who would like to go first?
I will have to say, this is Grace. And I first want to say, and be an encourager of whoever asked that question, I want to say that one of the things that's been helpful to me has been to participate with Diversity RX in the community of practice. One of the things that I think those of us who have the issue of resistance with some on a rather large scale, is that we need to know there are others like us out there who are struggling, and encourage one another. So I want to tell whoever wrote that question, feel free to email me, and we can. Sometimes you just need to blow off steam. So I encourage you to, with someone who understands. So I encourage you to do that. And I would also say, again, persistence. And I will also say that I did not do such a great, I've learned a lot of the things I've learned just in the last, it seems like, year or so, as far as some of the things Diana was mentioning, understanding from the perspective of those administrators what it is that they would want to see from their standpoint. What can I sell to them, if you will, about the important parts of the importance of cultural responsiveness, of having some sort of a formal committee or group who's charged with working in the area of cultural responsiveness, cultural competency, whatever you want to call it, because we don't have one either. I'm getting ready to meet right after this webinar with our Service Excellence department, and they are working very hard in the patient family-centered care, and that is a huge, I don't want to call it a buzzword because it's a concept that's at the center of good medical care. I guess before I ever started really working in medicine, I thought that was what we were all about. And I'm discovering that, it seems kind of new to folks. Oh, we're going to actually listen to the patient and find out where the patient is coming from. But we're working hard at it. So partner with those who are now, perhaps in your areas, thinking much more about how to work individually with our patients and their families, and take advantage of that. Diana mentioned it again. Think of what is it that they're out there looking for, the financial side, the satisfaction side, and use that to try to negotiate, at this point, a focus in that area of diverse care.
As a follow-up to that question, and maybe Diana or Mary could address this, to what extent and how do you do cultural competence or diversity education in your new staff member orientations? Is that a part of what you do, and how does it work?
Mary, you want to take that one?
I actually have our group that is working on revising that right now. The education group is revising that right now, so I can't speak exactly to that right now. Diana, do you have more information on that?
We don't do it in our new staff orientation, so that's one of the areas that I have yet to make inroads into. So that was an interesting question. I did want to comment on the first question, though, if I could. Mm-hmm. One of the things that I found really helpful was working in collaboration. In California, there's an organization called the Industry Collaborative Effort for Health, and it's a lot of the major health plans and insurers in California, along with the provider entities. So there are many of the provider groups and provider entities throughout the state. So all together we collaborate, and we started the cultural and linguistic work group long before there were regulations and too much from NCQA, and it was really a very effective collaboration. And one of the things that we started out doing was trying to tackle this question of cultural competency and education for staff and education for providers. And by pooling our resources, we were able to make big leaps with little investment in time and energy. And that in and of itself looked good to the organization. So all the organizations that were participating really kind of liked that idea. A little bit of staff time, but a lot of stuff for the return, for the investment. And the other concept is, one of the things that I keep in the back of my mind to help guide me is, as an organization, there's oftentimes the philosophy, and I think even in individual providers, is that if I treat everybody the same, then I can't get in trouble. But that's really the basis for disparities, and that you have to realize that everybody isn't the same, and they have different needs, and they need different attentiveness, and they need different accommodations, and a whole host of things. And so it's sometimes, finding that opportunity to challenge some of the really entrenched kinds of concepts through very easygoing dialogue. Just that, why do you think that's successful kind of thing? Just to open the door to thinking, not to convert anybody, but just to really open the door, beginning with those tiny little things that just crack open the door. And it's a long process, I got to say. So it's like begin, and persevere. That's what Grace was saying, and patience.
Great. Now, a couple of questions that we've gotten have been around the issue of getting feedback from patients about not only their needs, but what they think about the kinds of services that you're providing. And as a related question, perhaps, how you might address the issue of the cultural competence of patient satisfaction surveys. So who would like to take a crack at that one first?
We have the basic, this is Mary, we have the...
Just speak up a little bit, Mary. You're so quiet.
Yes. We have our basic QDM, which is our patient satisfaction tool, which is... Excuse me.
That's quite all right.
I have colds going around here.
Diana, can you talk to us a little bit about your experience with this?
You know, it is a big challenge, and we use standardized surveys because, again, they want to compare results across health plans within the state, and it's very difficult to get that kind of patient feedback. So one of the things that we've done is something that Mary spoke to, is that we have community advisory committees where we actually host meetings in the community, and we ask them specifically, you know, what kinds of issues are you finding in terms of accessing health care? Are you experiencing any kind of discrimination, language barriers, and bringing that information back from the consumer and taking it to our medical directors' meetings and sharing it with them on a regular, routine basis.
Great. Mary's still having a little bit of trouble. We'll come back to Mary on that.
I am so sorry.
No, that's quite all right. Take a sip of water and catch your breath.
I want to say that that's also, we are just beginning the Patient Family Advisory Committee. It's having its second meeting very soon, and that, I think, is going to be an excellent resource for us. For years, I've kind of charged myself with the idea that, at least for language services, I was going to get some kind of tool out there to have patients give feedback. I still haven't really dedicated much time to that because I know it's really going to be difficult because a lot of cultures, for one thing, don't do surveys a lot, and then time, who's going to fill it out, and what if they don't read, and what if so on and so forth, and what languages and so on. But we do have members of our advisory committee who are limited English proficient and deaf, hard of hearing, and people from all around this country, and that's we are beginning to take them some questions, and one specific question we're taking. There was discussion at a meeting on the callbacks, and I felt like the pain management questions were not at an appropriate level for health literacy. A lot of assumption in there as far as what people would understand. I think the question was, how do you have what you need at home to control your pain? And I said, what is what I need, and what is controlling pain? I mean, there's a lot of questions to me around that, and how we could ask that question so we really got the answers that we needed so we could help a patient through that. And those are going to go to the Patient Advisory Committee, and those patients are all going to be asked, would that make sense to you? How can we ask that? So when we follow up and call you at home, catch you in the middle of the day, you know that we're asking if you have Tylenol or the prescribed medicine, or the, for what, and whether you're having pain that's specific to your problem or just general pain. How can we ask that you'll understand? So I think for all of us, probably that kind of feedback, that kind of a committee is going to be helpful, and perhaps a little more helpful than trying to get a tool out there. That's my opinion.
Okay, great. One of the questions that we got for Grace, but I think might be applicable to all of you, is the question about collecting data within your organizations, and that can be looked at from a couple of different angles. I think maybe the first angle that we might ask you to address is what do you do to collect race, ethnicity, and language data from your patients or enrollees, and who does that, and how well does it work? And then if you want to, if you're not doing that, or if you want to address this as well, what sort of systems do you have in place to collect data about your interpretation programs with respect to encounters, what kinds of encounters, who does them, what do you use that data for, quality improvement? So just the general issue of race, ethnicity, and language and quality data collection systems?
I'll tell you that I think this is Grace, as far as the LEP piece and collecting, the preferred language piece, at least my organization does a much better job of that, I think, than probably the race ethnicity. Because in our work, it was so crucial for us to collect that data to make sure that we had interpreters available at the right times, that we really worked on at the registration end, the intake end, the questions to ask, and then where do you put that information so that it carries on into the record, et cetera. So and particularly for our outpatients, we do a good job. Now, inpatient, we use a different system, and we're going back and working on it. The outpatient up front in our system where we collect all the information to set up an appointment, we have a field for collecting the preferred language, and the question that's supposed to be asked at this point by all of our staff to every patient, which gets tricky, is there a language that you would prefer, in which you would prefer to have your medical care other than English? Something, I haven't expressed it quite right. And if so, what is that language? So we have a field for that preferred language. It's chosen out of a drop-down field, and every time we find a new one, we add something. And then there's a yes for an interpreter. That stays in our system for any outpatients we have. The inpatient side, that ends up being in the online, the electronic medical record, and we're actually taking time now to fix that section because it's not very, we realize it's not being taken into consideration every time as it is on the front end for outpatients. The piece we don't do so well, I think, is race and ethnicity, and I hear all over the country that's difficult. Maybe one of the other two has some good insight into collecting that data.
How about you?
Oh, go ahead.
Yeah, I think in California, again, we were somewhat lucky in that in terms of collecting race and ethnicity, the new law in California mandated that the health plans collect race, ethnicity, and language information, both spoken and written language preferences. And so that's one of the big benefits of the collaboration. When the regulations were released, the health plans collaborated together, and we did the research that we needed to do to develop a new code and category list for both race, ethnicity, language, spoken and written. We all had to update our databases to be able to capture all that information. For us, we found that one of the most effective ways to collect that information is directly from the subscriber, from the member, on contact from us. So every year we send out a couple of articles and postcards and newsletters saying, call us and tell us your information. We want to be able to improve our services. And we actually did see, in an odd way, we found that one of the most effective times of the year to send out that message was right around the holidays. And we think mostly because people were home. But we did see a fairly significant call in just to give us that information. But then we go on and we collect it throughout the rest of the year at every contact that we make. And across the board, we're at about 40% in terms of data collection.
Great. Mary,
we have the electronic medical record for collecting this data, and we do ask the registration staff, admission staff are the folks that are trained how to do the questions, ask the questions, and they're to ask them consistently. And for the ethnicity, it's a yes or a no. Are you Hispanic or Latino? Something about, I don't know exactly how the question's asked, but for race, and then there's drop-down categories that they fill in. And then the language is also their preferred language, and do you need an interpreter? And I think it has helped to have more consistency through the training of the registration people about the importance of this data collection. And we hope with our new electronic system that we're coming to that we can maybe add some more fields to that. And so we're looking at that and working with that group Our interpreter program is, the data is collected manually. As they have an encounter, they record their data, time spent, and I don't know the other categories, but they do collect specific information on each interpreter encounter.
Mary, question for you. Actually, and that was the piece, this is Grace. Ours is also collected manually and, frankly, input manually into a spreadsheet at the moment. We are trying to figure out how there are some scheduling systems out there specifically for interpreters that I think can collect some of that data for us if we were to, but we're going to have to purchase those, one of those, and they're costly. But frankly, we spend so much time, several thousand encounters. Mary, are you saying that's how yours are being collected as well? That would be an area I would think somebody could make a lot of money on if we all had time. We could design something, but it's difficult, very difficult to count all of that. Yes. And you have to have it for any plans you make, financially or otherwise.
So we have just a few minutes left, and what I'd like to, the question I'd like to pose to you is around something that Diana mentioned, which is the whole question on research relating to evidence of impact or benefit for culturally and linguistically competent interventions. I'm wondering if you could tell us each comment on this question of the evidence base and research that proves that providing particular kinds of interpreter services is valuable, or doing cultural competence training is value. Do you get those questions from the people that you work with, and what sorts of answers are you able to mobilize for them? How do you deal with that question? Grace,
Well, I will tell you the truth. We are still enough in the I'm enough the expert that if they're listening to me, they are taking my word for it that some of this is the case, that there are benefits financially, time-wise, for using, attending to people's language access needs, to their different culturally based needs. And I have to say, Diana and I got into this discussion as we planned for this, and Diana was the one who made the point that there isn't a lot of evidence out there. I will confess that I have done what some journalists tend to do, is I've read articles that say that the evidence provided stands up to this, and I've used those as my basis for saying there are studies that show, quote unquote. Now, I know that there's a study out there about the difference in using ad hoc interpreters as opposed to trained interpreters, and the danger around safety. As far as some of the other issues that we talk about, the time saving, the money saving, I frankly will speak as an interpreter on that standpoint. From my experience as an interpreter who interprets for and has interpreted, I don't do as much in the past, I don't really have time, but I was a full-time freelance interpreter for medical for many years, and I could give firsthand instances where I spent 6 or 7 hours with a patient in the ER who returned after inpatient procedures, and when finally, we all know how long the ER can take, she was triaged out as not a real emergent situation. She was there, they ran lots of tests, and did so, spent a lot of time to find that most of her issues related to her medicine and the side effects that she had not really understood because an interpreter had not been used with her when she was discharged. And I've interpreted so much, and for so many years, I can give many examples like that. So that's what I end up depending on rather than studies. So,
thank you. No, that's a good response. Sometimes the reality is what tells us what we need to do. Diana, do you want a little more that you want to say about that, having raised the issue?
I do try to keep on tabs of there's so many journals out there, but certainly in the last few years, there's been a lot of new studies coming out, and even though the studies tend to be very regional, it'll be at Johns Hopkins or at a particular healthcare system, I think the controls are sufficient enough that you can generalize the studies. Like I said, Berkeley just did one on health literacy, and that talked to consumers and said, you know, what do you wish the health plan could describe to you better? What do you wish they were doing better to help you understand how to use your benefit? So even those one isolated studies can go really far. And it is a challenge to keep up with all of those. And that's why conferences like Diversity RX and the Health Literacy Conference are so beneficial, is because you can one-stop shop kind of keep up with a lot of the research that's going on out there. And it's really been exciting, actually, I think, in the last 4 or 5 years to see so many people working on this in the medical establishment and actually doing studies that can be published and have the controls and can be generalized.
Great. And Mary, for the closing words, anything else that you would like to add on this topic?
Being an academic medical health center here, we do have researchers here that are involved. Dr. Warren Jones, Dr. Herman Taylor with the Jackson Heart Study, doing research on understanding health disparities in cardiovascular disease. I think the literature, the Joint Commission gives us information. I think the literature, the Diversity RX, the communities of practice, the listservs all give us a lot of good information to draw from, and I appreciate those references and those sources as I talk with others.
Great. Thank you very much. All right, Brittany, let me just ask you to show the next slide, which will just wrap things up for us. So if you want to pursue this topic a little bit more, first of all, I'll just repeat again that we're going to send all of the questions that you've sent us to the panelists, and we will ask them to try to answer as many as they can. There really are so many, and so I'm sure they won't be able to get all of them. And then once we get some answers back, which will probably take a week or two, we will post them on the webinar website, and we will send you an email letting you know that they are available. As well, the resource materials that have been mentioned and the recording will be online. The recording will be available next week. And after the webinar, we're going to be sending you a satisfaction survey so you can tell us what you liked and what we can improve on. And we'll be having another webinar on addressing language and culture in genetic counseling consultations on June 14th. And since you've signed up for this webinar, you will be getting an email advisory about that, so you can sign up for that one as well. So let me just thank our panelists who did a terrific job. I really enjoyed having you all interact with each other and to answer the questions and talk about your programs. And thank the audience for their participation. And if you need any more information about the Your Voice Project or Diversity RX or about the webinar series, you can look at our website or you can send us an email. So thanks very much for your participation.
Thank you.
Thanks, everybody.